Hello, everyone, and thank you so much for joining us today for the iCHOM webinar. Today, we're going to be discussing something really exciting, which is Tawuniya's transformation, a journey towards value-based healthcare and private insurance. We're absolutely thrilled you could join us this afternoon, and apologies for the slight technical difficulties. I think Zoom didn't understand that the UK is technically at summertime at the moment, so apologies for the time zone lapse. I'm Grace Jennings. I'm the Senior Director of the Outcomes Research Team, and I look after the set development piece. And I'm thrilled that we're joined today by some very illustrious people from the Tawuniya Insurance organization. Next slide, please. So Tawuniya is Saudi Arabia's largest and leading local private health insurer, and we are absolutely thrilled that they've become a strategic partner of iCHOM. And we're coming up to the anniversary of our official partnership signing. As you can see in this picture here, it was a great event, and we're absolutely thrilled that they are our partners going forward. So today, so you can see from that picture, it was at the iCHOM conference last year. So moving on to the next slide. We're also having our iCHOM conference this year in Dublin. And just to let you know that we have over 30 speakers confirmed already on our topic of vision to action, real results, real change for patients. And I think it's going to be a really great event with a lot of interesting topics, both speakers, side events, seminars, workshops. It's really hands-on. You can feel free to submit abstracts, as we'll come to in a second, but it's a fantastic opportunity to get together with the whole VBHC community. And please know that we're very close to the end of the early bird passes at the moment. So please book now before the end of the month if you'd like to save money on that. So I'd love to see you there. So hopefully we will see you in late September into October. And just to remind you that also, next slide, please, we are seeking your abstract. So please feel free to submit your abstracts by the 6th of May. And we select the top 5 abstracts for an oral presentation during the conference. And we look for about 75% of submitted abstracts for a poster display session. And we have a prize, which is the top submission is considered for publication in any JM Catalyst journal. So we'd love to hear about what fantastic work you've been doing in value-based healthcare. Doesn't necessarily have to do with iCHOM set. So if you have some work that you're really proud of, please feel free to drop us an abstract. We'd love to have a look at it and consider it for our conference. Next slide, please. So now moving on to the topic of today. We're absolutely thrilled to have several people from the Tawuniya Insurance organization. So we have Dr. Uthman Al-Kasabi, who's the CEO. We have Engineer Mohammed Al-Said, the CEO of the Health Sector Office. We have Dr. Hadi Al-Nazi, who's the Senior Executive Director of Quality Governance and Transformation, and Dr. Mohammed Kamal, who is the Medical Analytics Director. And I know that they'll be talking around a range of subjects all the way through this discussion. What would be fantastic is if you could drop your location where you're joining us from into the chat and any questions that you have. We'll get to the questions at the end, but in the meantime, if you have questions, if things come to you as we go through, please put them in the chat and we will have a moderated Q&A at the end of the presentations. So in the meantime, I will hand it over to our first speaker. Thank you all so much for joining today and looking forward to this webinar.
Thank you very much, Grace, and thank you for the for iCHOM for making this happen. We really believe on this partnership, and hopefully we'll make this great progress together. So allow me just to open the seminar, and I'm sure that among my colleagues there will be a lot of information to share, and it's going to be an interesting discussion where insurance company talks about value-based healthcare. So first of all, we're very much inspired by this by our vision as a country, where transformation is our health transformation is in the heart of it. It was made clear on day one from that transformation, from that motion, that is the direction. The very first paragraph in the National Transformation Plan spoke of value-based healthcare, that this wasn't an accidental, it was intentional. So, around 6 quick points, and each one of them is really kind of concise and sweet. So I just want to say insurance has a role. As the largest insurance company in the MENA region and also in the kingdom, we at Tawuniya believe that value-based healthcare isn't just a provider story, it's our story too. It's not a buzzword, so it's not a slogan that we're using. For us, it's a strategy, not tomorrow. So we are, not waiting for the value to be created. We are trying to build it now with the great partnership that we have with iTrump. If we talk about sustainability, so fee for service, we know that it is not sustainable for us. So we are trying to, and we believe that value-based care can create that sustainability. And this is cannot happen without partnership. So we are not doing this alone. We are this transformation takes an ecosystem, and it takes always two to tango. And at the end, the shift is kind of what we need to thrive for, and we're not rather leading this shift other than to be disrupted by it. And we're kind of going with that flow, and we believe that it's the future of the healthcare when it comes to ecosystems, whether you are a provider or a payer or a patient or a person, because we're really interested about investing on the human well-being. So I hope that you enjoy the workshop or the seminar with the 3 pioneers of Tawuniya, and I wish you all the best, and hoping that we will contribute to the knowledge of people who are interested in our talk today. Thank you very much.
I'd like to invite our first speaker, who will be Dr. Khadi Al-Anazi, to talk about VBHC in the healthcare industry and why VBHC made so much sense.
Well, good afternoon, good evening, everybody. Thank you, Grace. Thank you, the iTrump, for the opportunity. It is such a wonderful opportunity to exchange expertise with the wider community among all different regions in the world. And there is this webinar presented by Tawuniya shows our commitment as a private insurance company to this journey. And I will walk you through the why, showing some numbers as Deming, the guru of the quality, said, in God we believe, for the rest bring data. So we're gonna share with you some important data numbers to show why value-based care is not a buzzword. It is not good to have. It is actually a mandate for us in this ecosystem to be able to sustain affordable care for our clients. Next slide. This is from our GCC country, and if you look to the dynamics of the economics of our nation and the GCC, you can see that 7 of the non-communicable disease is almost consuming 1% of our GDP. This is on the long term. We're going to threaten the whole economy of the whole nation, not only the healthcare industry. Next. And if you want like a deeper look in our data, I can share some data from the health Saudi industry, you can understand the why, because only 4% of our expenditure in the healthcare is directed toward the prevention, while the rest is all directed toward the curative, reactive aspect of the healthcare. Next. And this will explain why the inflation in the healthcare costs that will make the industry unsustainable. And if you look to our potential inflation rate of 16% compared to the rest of the world. So as a nation, we realize that for the health system, for the whole industry to be able to sustain providing care, something needs to be done differently. Next slide. Just if somebody might consider that spending more will translate into a better health outcome, we actually can reflect to some of the other healthcare system in the world. And the US is a typical example where they are spending double of the OECD on the healthcare, and yet their life expectancy is much lower by 3 years compared to the average OECD country. Next slide. And you can see this also in the preventable death in the US and across all ages. And even if you look specifically at infant and mortality, you will find there is no correlation between spending and the ability to have a better outcome. Next. If you wonder where is those expenditure is going, you can look at the EBITDA, which is the revenue by the private sector in different nations, and among which our nation can range up to 25%. While this is good on the short term, we know this inflation, along with this income on some aspect of the health delivery system, is non-sustainable. Something needs to be done different. Next. And nationwide, internationally, it's been documented that up to 25% of all what we spend is actually what we call as waste. In healthcare system in Saudi, we don't know exactly what is the waste, but there is no reason to expect that it's going to be any different or any better. Next. So in summary, we're in our healthcare system currently, we're very reactive, and that's expressed again by 35%. All the deaths in the KSA are caused by the non-communicable disease. We're very disease focused and oriented, and if we to focus and realign our healthcare delivery around population health management, 200 deaths can be prevented by simple being focused on the customer rather than on the disease. At the end, we're very costly, and again, 30% of this cost is translated to absolute waste. Next. So the answer is very simple. We need to be proactive, we need to be health-oriented, and we need to be very cost-sensitive. That is easily said, but the execution is where the whole complexity occurs. Next. So what we've done in Tawuniya, we looked how we're going to do something different for our population. So we are adopting the principle of population health management. If you Google or try to search what does the population health management, you can have many different answers to the question. So what we've done in Tawuniya, we reached out to all the key international and local expert to come with an executable definition of the population health management. So we have our own definition in Tawuniya of population health management, and it is a compromise of 4 B's, the design principle, and the 3 C's, which is the implementation principle. So for our BHM program, it has to be a program, means simply it has to have well-described start and end with very clear KPIs. And the KPIs, we adopted the triple aim of the IHI, which is cost, quality, and the clinical outcome. And it has to be personalized, mean it is described to an individual need, it's to group of patient, to a region or to a policy holder, and it has to be proactive. And when we say proactive, it is the 4 level of the prevention to either primary, secondary, tertiary, or quaternary. And again, the whole care has to be shifted back to be community-based. It's part of the living healthy in the community. It has to be continuous through the different spectrum of life and health, and it has to be built on a very robust case management. Next. To do and execute of all these programs, we have to apply the principles of the value-based healthcare. So now we have our well-described program. We are executing them through our value-based health program. My colleague, Dr. Kamal, will walk you through the journey of this execution.
Thank you, Dr. Hadi. I think it's clear now why we started our journey toward value-based healthcare, and a core driver of this journey was the digital transformation, specifically how we utilize AI and analytics. With over 3.1 million members insured in Tawuniya, it's essentially that we understand not just the population, but the person. Using advanced risk stratification models built on medical data, we identified who needs care most and personalized our approach to deliver the right care at the right time in the right way. Next. So our journey began with a discovery phase to deeply understand our population and their risk, starting by the Charson Comorbidity Index, a validated tool that was developed by Dr. Mary Charson in 1987, converts a complex health profiles into numerical score by weighting the severity of different chronic conditions like diabetes, heart disease, and cancer. By applying this model across all our population, we transformed raw medical data into actionable insights, providing a foundation for proactive population health management. Next. The results of stratifying this population is segmenting the 3.1 million members into 3 categories. So we have mild, moderate, and high-risk categories. This helped us to direct our resources toward those who need more care, enabling proactive health investment. With over 500,000 members identified as chronic disease patients, such as diabetes, respiratory illness, we saw a direct correlation between increasing cost and increasing risk, which proved the need to intervene early. Next. We wanted the care to be personalized, so we built an in-house generative AI solution using large language models. This tool automatically synthesizes structured data like claims, pre-authorization, with unstructured data from clinical notes in order to generate concise and holistic patient summary. It empowers our care team, care coordinators, case managers to make faster, better informed decisions, enabling timely intervention and improving quality of care. Next. Of course, prediction is the best prevention. And as most of you, we know that diabetes is the highest health burden globally and in Saudi Arabia, both clinically and economically. And that's why we invested in health prevention, and we created an AI-powered diabetes risk prediction model trained on big data of our members, combining lab results, medical history, and lifestyle data to flag members at high risk of developing diabetes. This proactive model enables timely clinical action, reducing long-term costs, and most importantly, helps our members stay healthier for longer. Next. As Dr. Hadi mentioned, it's central to our transformation is this between the best possible outcomes and sustainable cost. So it makes sense for us as an insurer to invest in the health of our members because we want them to stay healthy. We aligned our clinical programs with ICHOM's global standard sets. This allowed us to benchmark our performance internationally and ensure that our measures are globally recognized. Next. As I mentioned, we aligned with ICHOM to measure what matters most to our members. This alignment process involved 4 key components. So first, outcome selection. Second, measurement approach. Third, our value framework mirrors the triple aim. So our triple aim framework, improving health outcomes, reducing cost, and enhancing the member experience. It aligns with ICHOM framework of improving care, comfort, and capability. And finally, we have translated and localized these standards into Saudi context. Back to you, Dr. Hadi.
So far, we've shared with you the reason why. Then we shared with you our own local data and the design principle of how we're going to approach our journey toward the value-based healthcare using the BHM principle. Then we walked you through Dr. Kamal's presentation on how we segment our patient into a design program. Now I'm going to walk you and give you an overview of how we are executing this program. Next. So as Dr. Kamal said, we have the segmentation done, and using the preventive principle, we have for each group well-described program. So we have our high risk, we have our moderate, we have our low risk, and for each of these segments, we have very well-described program that we can execute with them into being proactive and preventive. Next. And we know for this complexity, you cannot execute the program unless you have the digital capability, which we are built already for in our program, and the very robust case management, which will ensure the care is continuous and coordinated. So we have a very well-established case management program for each of our segment of the population, for each of our program, that ensure there is a full journey of our clients being taken care of in a proactive and preventive way. Next. So in the era of the healthcare transformation, we know, as described by our transformation principle in Saudi, that this transformation of BHM or value-based need to be built around very strong primary care. And the way we define primary care in Tawuniya is where we reach to our clients at their convenience. So we reach to them digitally. If we cannot reach them digitally or care need to be delivered physically, we go to their home through home care program. If we still need to be reach out to them other than the home, we'll go to where they work, in their workplace. And finally, if they need to come to us, we built a state-of-the-art, customer-centric primary care centers to provide the full canvas of our earlier described BHM programs. Next. For this purpose, Tawuniya board has established an independent company for primary care and BHM called MENA. MENA is actually our population health management execution arm that's provide full scope of digital, home care, physical, and virtual to provide the whole scope of the BHM program in a preventive, proactive way. We're very happy that this integrated care now is being applied, and as we speak, we can share with you some of early outcomes of our journey in the value-based care and BHM. Next. We have what we call it value-based healthcare dashboard. For each of these programs or for each of these clients, we actively monitoring our triple aim. We look for their clinical outcomes, we look for experience, and we look for their financial outcomes to ensure that for each of these programs, for each of segment of clients are being monitoring actively through the dashboard. Next. And I'm very proud to share with you outcomes from the general journey in our population health and value-based healthcare. As you can see to the left, as we increased of our number included in the BHM program, you look to the middle slide where there is decrease in their frequency of admission, and at the same time, there is a decrease in their length of stay. Someone might wonder, if you are doing that, is that at a cost of exposing them to risk? Next slide. So the answer is actually no. We have documented, we have a less readmission rate their hemoglobin A1C, which is one of the indicator we monitor, is coming down, and their cost per member, or the financial cost, is actually trending down. So a very well described intervention program using the framework of ICHOM for the monitoring the quality, cost, and experience. We've seen it in action that is actually satisfying our client, improving their health, and at the same time decreasing their cost. Next. And now that was a general. Dr. Kamal will share with you a very well prescribed intervention program using the well-described ICHOM set. Dr. Kamal?
Thank you, Dr. Hadi. So as we progressed in our VBHC journey, we realized that success depends on building trust with providers, as mentioned by Dr. Osman in the beginning. So it's all about building trust. Contracts alone do not change behavior. Relationships do. So the transition from fee-for-service to fee-for-value starts with trust, transparency, and aligned incentives. Our approach was to start small, demonstrate value, and we co-created these contracts with providers, embedding outcome-based metrics rather than relying on volume alone. Next. A powerful example of this collaborative model is our cataract care project. We selected cataract as a simple condition, short episode cycle, and less variation. We began with this simple use case at small scale and no penalties, building an environment of trust and a win-win relationship. We partnered with 3 providers and collected the ICHOM CADQuest 9 SF questionnaires for over 280 patients. This allowed us to evaluate outcomes before and after surgery, creating a shared measurement framework. If you can see on the right chart, the preoperative PROMs in red were in the far negative side, while same metrics post-surgery in green are in the positive side, reflecting realized value by our members. This feedback was not just used for reporting, but for improving care quality in real time. This early collaboration became a template, showing others that once trust is built, more providers will seek to join. Next. Once we built this environment of trust, many providers approached us. So in August 2023, we launched Saudi Arabia's first value-based bundle payment. This program covered 3 spinal surgeries, disc herniation, lumbar canal stenosis, and lumbar fixation, and included the surgery plus 6 months follow-up and complication coverage. We integrated PROMs, PREMs, and CROMs into the bundle, ensuring that we measure not only the cost, but actual improvement in patient lives. Other providers are now approaching us as they see the value. So far, we have enrolled 119 patients, and early results show improvement among patients created at value-based healthcare aligned providers. Next. If you can see here, our comparative analysis reveals a promising cost advantage with our VBHC approach. When comparing traditional fee-for-service providers to our VBHC partners, we have documented substantial saving across all 3 procedures. These financial outcomes validate that quality improvement and cost reduction are not competing goals. They are complementary when care is properly structured around value. Next. Our patient-reported outcome measures tell an even more important story than the financial data. Patients enrolled in our VBHC spine program reported dramatic pain reductions. So back pain scores dropped from 7.8 to less than 2, with sustained improvement at 6 months. Leg pain show even more dramatic improvement from 9.1 to below 1 at 3 months. These are not just numbers. They represent real people returning to normal and pain-free life. Moving to the next slide with functional improvement across multiple domains that demonstrate the comprehensive impact of our approach. Patients reported substantial gains in daily activities like sitting, standing, social interaction, with disability scores dropping from severe to moderate to minimal across all categories. These functional improvements translate directly to better quality of life, workforce productivity, and reduced long-term healthcare utilization. And moving next to the future. So what we showed, next slide, please. What we show is only the beginning. We are now expanding clinically into diabetes care, rehabilitation services, and geriatric care programs. As trust grew, we moved from simple to more complex arrangement, creating a win-win relationship. In order to scale, we need a digital enabler that ensure data collection and outcome tracking are seamless and secure. One key lesson learned that understand the process before you apply the technology. We took time to map our internal procedure, identify pain points, and determine which tool best fit for our need. This helped us avoid misaligned solutions and ensure better outcomes. Next. So one of the biggest barriers to VBHC adoption is provider hesitation, and we can understand that. To address this, we started our journey by collecting prompts only in cataract case without discussing any financial. Then, once trust was built, we introduced upside-only incentives in spine surgery without discussing any penalties. It took time to collect data, so initially we took the burden of data collection through our call center to reduce the friction on the providers. By demonstrating value in low-risk environment, we created the foundation for long-term partnership. We also learned the importance of understanding our financial baseline and starting small. Early pilots helped us identify what kind of technology and process worked for us, patients, and providers before we scaled them. This phased, flexible approach proved essential in driving adoption and building momentum. Now, back to you, Engineer Mohammed Saeed.
Thank you very much, Dr. Kamal. Thank you very much, Dr. Hadi. So one thing that we wanted to do in Tawuniya is how can we put everything that has been discussed in this presentation, because it can get very overwhelming, it can get very complicated. So we put a challenge on ourselves. We invited, I think, about 20 people inside one training room, and we said we want to put everything we want to achieve in our transformation in one slide. And we came up with this a model that we are very proud of. Of course, it starts all with the segmentations of our population, with the different risk stratifications, the low risk, the medium risk, the high risk. Very briefly, the first starting point is how do we create personalized programs? And that was the first point, based on their risk profiling. We do that in collaboration with the experts in the fields and in the specialties, but also with the support of ITROM. It is a very reputable organization with reputable referencing, and it's helping us a lot in developing these programs, and these as they are listed here in under each one of the risk profile. Number two, a big barrier and challenge we have is the provision of primary care. We wanted to make sure that it is being delivered at a very high level, at very high standards. So we created a subsidiary, a sister company for Tawuniya, to deliver the primary care through its clinics under the name of MENA. And it provides through three different channels. There are the physical clinics, and they are based on a community-based to be close to the members and the patients. It is through the digital platform with world-class application, and through the home health care, bringing the provision to the members, whether at their home or in their office. After that is we have created 3 streams. One is for the medications services, the other one is for inpatient services, and the third one is the outpatient services. The route for medications is through automated pharmacy benefits management to ensure that there is consistency, there is formulary being put in place, and clarity and consistency in all channels of provision of care. The inpatient services is through the implementation of DRG to avoid the confusion, to avoid the inconsistency, to avoid having the patient and the member being in the middle with misaligned incentives, and also to eliminate the need for overutilization and waste in the journey. And we are going with DRG as the solution to this area, which makes about 30% of the healthcare. The third one is the outpatient services, where it makes about 50%, and we are developing integrated rules engine based on crosswalks and utilizing the amount of data we have and going from retrospective, reactive to prospective and proactive at pre-auth level before the service is given at the point of care inside the clinic of the physician to know what are the rules and guidelines to be followed. The enablers we have are in the horizontal area that we have, point 7, 8, and 9. For the continuity of care and to make sure that the whole loop of healthcare is covered, we have developed centers of excellence in the referral matrix from the primary care to the secondary and tertiary care, and they are based on the three aims that we have in Tawuniya: the cost aspect, the customer experience and satisfaction aspect, and of course the medical outcomes. And then the closing of the loop, going back to the primary care with the medical reports to ensure proper continuity of care post-secondary and tertiary treatment. Point number 8 is the value-based contracting that Dr. Kamal covered in more detail, and we put in our mind that we work with the providers, not against the providers, not for the providers. So we are into this together as stakeholders with common objectives and common aligned incentives through value-based contracting rather than rewarding volume and fee for service. The last but not least, the digital transformation. Without digital enablement, none of the above can happen. Technology is in our side currently. It is there with the AI, with the integration, with APIs, etc. With data mining. It's so many tools put together into the digital transformation to enable us go from the legacy painful healthcare system into value-based care model. If we go to the next slide, the lessons learned from our journey, we started this journey about 1.5 years ago or so, is that number one, it starts with the mindset. It is very, very difficult to change the legacy mindset, and because the definition of value-based care and the end goal requires a lot of changes with many stakeholders and putting a lot at stake and a lot of risk with the legacy current system. If the mindset has not changed and believes that this transformation is needed for the sake of sustainability, for going from a legacy system that is not working, is not for the sake of the patient and the member, then going with the journey will be very heavy, and it will not continue, it will not be sustainable. The second lesson is that start with pilots. The transformation journey and the end is very big and it's very far. Unless there are small steps, if there are no small success stories and implementations to keep the energy going, to keep the motivation, to keep believing, then again the journey will seem heavy, and you will stop somewhere in the middle of the transformation journey. Again, I will mention that working with the providers into this, align the incentives, get them on board, you can find the win-win. And in our journey, we have learned that there are so many providers, once they have the shift in the mindset, they realize that it is a win-win. It is not an impossible formula. It's not easy, but it is doable. Again, culture is the hardest part. The stakeholders are a lot. It's very complex, a lot of interdependencies. But once you utilize the data and convert, let's say the subjective philosophy and theory using data to change the culture of the whole organization and the whole system, that's something that we realize that it starts from the top, and it's a very important a pillar into the value-based care journey. And finally, invest in the listening infrastructure. There are so many stakeholders. Each one has a reason of why the legacy system exists, why the transformation is difficult, and they can find so many reasons to prevent it from moving forward. Building collaborative mindset and finding the settings and investing time, energy, doing these kind of events. And we thank ICHOM so much for taking the initiative and bringing the different stakeholders here into one forum to keep talking about it and putting the right mindset of the leaders and the stakeholders towards value-based care to maximize the benefit for our patients and our members. Thank you very much. Here, I would like also to take advantage of this opportunity and this forum to announce something that we are extremely proud of, is bringing the different stakeholders to Tawuniya's R&D, research and development. We have so many entities here, whether from the educational system, from the provision healthcare, from regulatory bodies, from insurance, of course, ourselves, taking the lead into this. It was so much effort. I mean, it's summarized here, but we really thank all the names that we have here, and bringing these different entities together has put so much credibility into this. They are all leaders with very strong voices. Whether in the digital, in the clinical practice, in the wellness and health promotion, in occupational health. It's really something that we're really proud of, and we are going to officially launch it on the 18th of May. So we invite you all to join us. Let's be into this journey together, and unless we all put our hands together, we want to enjoy moving in towards this transformation together. Next slide. And that's the QR code. One part that we're very proud of and keen of in Tawuniya is having white papers, communication. And I would like to thank Dr. Hadi and Dr. Kamal from Tawuniya's team, ICHOM. We can't thank you enough for having this. All the members I see, very, very impressive, about 170 participants here. It's really great. And let's embark into this journey together. We have gone a long way. We're not going to start. And the small steps and the small achievements that are happening, they are going to accumulate. And hopefully, in a few years down the road, we will have a very nice success story to be shared, and the journey will continue.
Thank you all very much. That was a fantastic set of talks. We have a lot of questions to get through. So I think I'll start with a slightly easier one, hopefully, which is a few people have asked pretty much the same question, which is how do you collect data for ICHOM and other patient experience and outcomes? Do you use apps? Do you contact people by phone? How do you actually collect the data?
Dr. Kamal?
So start simple. This is our advice. Our first use case in cataract, we used our own call center agent. They were calling the patient and they were collecting the prompts from them. So no burden on the providers. There is no additional cost on us except our call center agents. Then when we progress to spine surgery, we partner with the provider to collect the prompts from their side. So a care coordinator was assigned from the provider side to collect the data. And then once we reached the level of maturity that we understood the process from our side, understood what is better for us, for the provider, and of course, the patient, we started building our digital tool to collect this measures from the patient. So a QR code or SMS message or WhatsApp message or even a relative for the patient can fill the questionnaire and send it back to us and the provider in a digital way.
So moving on from that, we've actually had a lot of interest in the spinal surgery sort of case study. Let me read one of the longer and more detailed ones, which is thank you for sharing the cost savings achieved on the spinal surgeries in particular. Cost saved by the insurance typically means income lost by the providers. Has there been pushback or concerns raised from surgeons or hospitals on this program? Also, in what areas were the cost savings realized? For example, shorter hospital stays, use of less expensive implants or materials.
I'll take this one, if
Excellent.
you allow me, Dr. Kamal. So I will answer the provider question regarding the resistant. It is a very simple formula. If we manage as an industry to have a better cost, then it's simply you will have more direction of volume. So instead of you making a big ticket item on one case, you can have a smaller but sustainable flow of patient. The details of the income, Dr. Kamal can elaborate on. Dr. Kamal?
So this is the magical word, the volume. If you want the provider to be aligned with you, refer more patients to them. They will gain less profit on the short term, but more sustainable and higher volume and value on the long term. And this is how we design the journey with our providers. The fee-for-service model is not the ideal model because we know we have to pay each and every additional service, even if it's not that indicated. But building the model around the value of the patient is more sustainable from clinical perspective and also from financial perspective. So again, you can compensate the short-term cut of cost by managing higher referral and bigger volume to the provider.
Fantastic. We have a couple of other questions on fees. So how do you ensure that bundled payment models don't incentivize providers to cut spending on essential resources just to increase profitability? And that kind of goes along with how do you ensure you don't lose the richness of line-by-line claims fee for service data as you move to bundled fees? So how do you deal with the data issues and the sort of incentives, which I know you mentioned, but...
So it's all built on a very robust open communication and the ability of digitally to monitor our outcomes. So we look for a trustable provider, like it's a journey. So we have an open communication with our provider network, and we critically monitor all aspects of care journey to make sure that our triple aim is maintained. The quality, the clinical outcomes, and the cost. We have very pre-alignment on the journey with our provider before we embark on the outcomes. I'm sure engineer Mohammed has some thought to share. Abu Aziz?
Yeah, absolutely, Dr. Hadi. I mean, it is a very good question. However, first, it starts with the selection of the provider. If he has the right mindset and he believes in the value-based care, then he will be embarking on this journey. The other thing is we look at medical outcomes in addition to the contracting commercial part. And we face this challenge in the DRG, or learning, let's call it, from the DRG implementation, where we have a huge amount of data when it was fee for service versus a DRG where it can be just one code that summarizes everything. So we agreed with the provider that we still want to see all the services that are given below that DRG code. It will have next to it a value of 0, but we wouldn't lose the data and the opportunity to continue to analyze the services given to our members and the patients.
Right. Now, I have a couple of questions about preventive care, sort of as like a bundle, you might say. So this is all about preventive care. So the first question is, why is it still underfunded given its proven cost effectiveness? Are there successful international models that Saudi Arabia can learn about in preventive care? And how can the private sector be better engaged in supporting preventive care efforts?
A great question. I think it's a journey. So these data that I shared with you was back from the year 21. We have a major change in regulation in the private sector where preventive services are now actually covered by the insurers. And we do encourage our clients to go through the primary prevention because we do believe for us to sustain a health and a healthier population, we do need to invest in the primary and secondary prevention. It is a change in mindset. So how can we work with our provider network to spend the money on the prevention rather than waiting for the complication to happen. It's a big journey. We've started with our subsidiary company, MENA, to encourage and show that you actually can make a profit if you invest in primary prevention at a sustainable growth. So it's a long journey. We started to see an early adoption in the market, and through this webinar and learning this together, I'm sure we're gonna see, inshallah, a bigger improvement in how much we're gonna spend on the prevention.
Right. So we have a few sort of, slightly, I want to call them random questions, but, not really connected to other questions. So how can CGM technology participate in the targeted outcomes for your DM customers?
That's an interesting question. So the answer, we call on the expert to show us the triple aim impact. So we are in the learning journey, and one of the biggest projects that currently we are working with ICHOM is on the diabetes. If you look to the diabetes in Saudi Arabia, it's almost 25% of our population. Either they are pre-DM or DM. And we do know that investment in the all level of a prevention and DM from primary, secondary to quaternary, including the CGM, will have an impact. But which segment of patient and what kind of contractual agreement that will have the strike balance between the triple aim outcomes, between the experience, the clinical, and the cost. So I would say we're in the early exploring phase on this journey. And we will welcome, by the way, any interested parties or people to exchange experience with us. We shared our value-based healthcare email in the slide, and please feel free to reach to us. We want to do this together.
There are a lot of questions sort of asking about partnerships and international sort of collaboration. I'm trying to pick one, but I'll just ask one about scaling cataracts first. I think that was quite an interesting one, which is, where did you go after the cataracts pilot? Did you continue with an upside risk payment model, or change to perhaps upside downside, or bundled system like you did for spinal surgeries?
Good. So, so we are exploring different disease or condition. Cataract was a simple one to attract. Once we learned cataract, we went on to look to the back surgery. What we've learned from back surgery, we are now into the more complex condition, the diabetes and the geriatric. So it's a long journey. Now we are into expanding our provider who want to be capitalize on what we learned from the cataract and the back surgery. Dr. Kamal, anything you want to add from your side?
Yeah, I agree with you, Dr. Hadi. It's a journey. You cannot start with downside penalties in the first step. This can be. So as always mentioned by Scott Wallace and Elizabeth, measure simply, but simply measure. So you need to start in a simple way. So we started with promise collection without any financial. Then we started with the upside incentives. And then down the road, we will move to the downside incentive. But we believe that building trust is the first logical step.
And speaking of scaling, what considerations are being made to scale VBHC initiatives to include other high burden conditions like diabetes or cardiovascular disease within the Saudi private insurance market?
This is exactly our next step. So we already have an agreement and a program with MENA, our trusted partner, to start delivering the diabetes care through the VBHC model.
And how is VBHC supporting mental health care pathway, especially around the prevention side?
Well, we know that mental health is one of the 48 conditions on the ICHOM datasets, and we are planning to implement it. However, as we mentioned, and I will restate it again, it's a journey. You cannot start all the conditions at the start. Specifically, this mental health condition is far more complex than straightforward surgical procedures, for example. So it's down the line right now. We are started to do the HRA, health risk assessment, to our population to understand who needs the mental health programs.
Exactly. If you allow me to add, as Dr. Kamal, maybe very specifically unique to our culture in Saudi, there is underreporting, underdiagnosing of the mental condition, for which we do understand the need, and we started what we call the health risk assessment, which is a very well-known tool that will help us reach out to our clients who need help without the worry of them being labeled or the stigma of this condition. So we are very aware as industry of the need and the potential impact, because we know for a fact if we don't pick up and recognize and handle these conditions, they will come up as headache, as a chest pain, as just name it. So it is the interest of the clients and in the industry to go after addressing the need of the mental health for our clients.
So you
Abu
feel
Aziz, you wanna add?
disincentives would be addressed by that?
Yes, exactly, Grace, and that's what I wanted to add. One thing that is also exclusive for Tawuniya is the partnership with the Discovery through Vitality, where we have we monitor the behavior of the members through wearables. So we see the steps that they take, sleeping habits, diet habits, heart rates, etc. So it makes us understand and know early in the game if this member is at risk, is going from the low risk to the medium risk, and we start proactively doing personalized programs for him to ensure that he remains in the healthy profile.
Absolutely. Okay, so we have a few questions around the data platform, how you bring data together. So I will try and tie them together, but basically, how do you collect data from the DRG and use it with patients? How do you compare the results collected on your side as a payer to the one collected on the provider side? Could it be smoother using a single platform shared by the payer, provider, regulator for collecting PROMs and PREMs? And do you think there's any way to improve the response rate? You know, have you thought about having a minimum threshold for response?
I will start with some general answer, and maybe Dr. Kamal can elaborate. Of course, in Tawuniya, we have maybe the privilege that we have is we have about 35% market share, of the population. We have over 25 million claims that we receive annually. So we have a lot of data that we are receiving. However, the more difficult part is how can you convert this data into stratification? And that's the effort that we took over the year and a half, and we're still investing in the digital transformation with the PHM portal to automate and have higher quality and accuracy of data with the diseases and with the risk profiling. We are just about piloting and testing our health risk assessment, which will give us, proactive data and understanding of the members. Many of them are young and healthy, and we don't have claims data for them. So going to them proactively through our Tawuniya app, through WhatsApp, through SMSs, through phone calls, through healthcare launches inside the companies. There are so many forums that we have to collect the data. We have wealth of data, but the difficult part is that it is scattered. How can you collect it and organize it with the data mining tools and techniques to get results out of them? Dr. Kamal, if you want to add.
Thank you, Engineer Saib. So, of course, our golden rule is data privacy and proper data governance. So we make sure that we take the proper consent from the patient. We maintain the security layer to make our data inaccessible to anyone that is not authorized to check it. And then the next step is to centralize the data collection within the insurer. So we make sure in our agreements with the provider that there is a centralized and transparent way of data sharing so that we can compare and benchmark the provider of different providers. One of the questions you mentioned is about the increased engagement. Yes, engagement, it is a challenge, and I think this challenge is globally, but the way we are tackling this challenge is by having multiple ways or multiple channels for communication, so we can start based on the age group and the demographic. Some patients in the younger age would respond more to digital communication ways like WhatsApp or SMS message, and the elderly population, they prefer direct calls from a care coordinator or even one of their relatives to fill the questionnaires on their behalf. So multiple channels of communication, trying different ways, and always try to approach the member on the right time for them, because we have noticed that some patients respond more in the morning period, others respond in a better way in the evening period, and having the centralized data secure layer.
Let me add, Grace, what briefly we said about the BHM platform. So as we speak, we can have some data through claim about our client. We can have some data through the HRA for our client. And what we are doing using the AI and the digital capability, we collect these data to have a personalized plan of care for our clients. So currently, for each of these touch points, each of our clients, we can provide through the AI capability a detailed report detailing their personal care plan that's sent to their primary care provider for execution. And this is, as we speak, I would think one of the innovation that we're very proud of, just to make sure that we eliminate the waste and repeated the unnecessarily lab or doing harmful procedure, and making sure that whatever intervention are tailored to the unique need of that beneficiary.
Right. So I have a sort of follow-up question about sort of data quality. So not necessarily data governance and data protection, but how do you make sure that we all know that data in the real world is super messy. How do you make sure that the outcomes are reliable and robust, comparable, possibly creating benchmarks, etc.?
I can take this. In Tawuniya, we have two separate functions. So we have the health governance and the quality. That's, for example, falls under my supervision. And Dr. Kamal is the director for data analytics. And in the operation side, we have what we call them the excellence team, where they have very different report structure and they monitor the outcomes exactly in the similar way, and at the end we compare and contrast, so we make sure that there is a robust check and balance between what governance can see and what the operation can report. So even for the outcome of our clients, we have a different way to look at the quality of the data. Great question.
So we have a question from the chat, which is, there are two questions. Has there been a cost comparison to explore how the uptake of MENA services is changing, cost per policyholder? And for the spinal case study, the cost savings are for small numbers of patients. Will this case study program be sustained to understand longer term outcomes, including comparisons to control patients?
I'll take the first question on MENA. And as a matter of fact, just last week, we've been in our board discussion to make sure that whatever we are caring for MENA meets the triple aim. And we're very happy to report that our clients that receiving care in MENA have a better clinical outcomes, a good experience, and at a trending down cost compared with the market. So we are now in the phase and era of opening the door for other primary care providers and community service, because as Tawuniya, we know we cannot only use MENA. MENA is one of many providers, but we want to invite all the primary and community care services to come and join on the journey of the transformation. Dr. Kamal, if you might take the question on the back surgery.
So the next question, it's about the sustainability of the cost effectiveness of the VBHC and BHM. So if you check the literature, you will find a lot of health economic studies that have been published about this. There is normal increase in the cost initially because of the investment. You invest in the health of your members, and then down the road there is a reduction of the cost, and then there is a plateau phase that, okay, there is no more intervention that you can do to the patient, and just you want to maintain the same level of health so that you can maintain or control the inflation for this. So what we have been seeing in less than 1 year, it's actually promising. It's even better than what we have checked in the literature. And this gives us a hope that down the road, we will have even more promising results than what was published in the literature.
And a couple more sort of quite granular questions. Did the providers participate on the fees defined for each bundle?
I can take this, Grace. Yeah, absolutely. I mean, all the initiatives, and projects and the journeys were done in collaboration and designed with the providers, whether the cataract example or the spine example, even the DRG implementations, the PBM implementation. And that's one of the things that was the beauty of the journey that we are in so far, that it is done with the collaboration of the providers.
And does this journey align with the vision of the country 2030 in a sustainable way and along with corporate fiscal responsibility?
Yes, absolutely. I mean, it's driven by the Vision 2030. It's supported by, we have seen so many regulatory bodies and government and semi-government entities fully supporting this. And, the overall infrastructure in Saudi Arabia has been a great enabler into this. One of the things that give us an advantage is the unified IDs that can be used across all providers and touch points. Which makes the data, there was a lot of questions related to data. So that makes it relatively easier. We have standardized sets of coding for services that is standardized in the country by the regulators. So they are fully supporting this journey. The ICD-10 for diagnosis has been standardized. As I mentioned, the DRG coding for inpatient has helped a lot in standardizing the codes and converting them into useful analytical tools.
Okay. And could you discuss how you have or plan to leverage competition in your model?
Well, I mean, the general answer is that again, we have the majority of the market share, and I think once we prove that transformation to value-based care is a reality, then I think the rest will follow. And again, that's why we believe it is a win-win. We are not worried if competition will join. To the contrary, we'll be happy. At the end, the patient, the member will be satisfied, and the outcomes, the positive outcomes, will be yielded to all stakeholders.
And how do you integrate between the different payment models as DRG or other for IP?
IMP, I'm not sure what.
I'm not quite sure. I mean, maybe implementation, I guess. I mean, for me, it would be interventional procedures, but I'm not sure.
Patient, maybe?
Maybe.
Inpatient. Yeah, so it has been a challenge to go from fee for service and inpatient, whether medical or surgical procedures. The worry is that having just one code with one payment associated with it, regardless of what is the potential services that will be given to the patient, was the biggest challenge in implementing the DRG. And that's why we are doing it with really trusted partners from the provider side. And we're doing shadow billing with them to ensure that the risk is mitigated before we roll out and implement in the transformation.
And another question about primary care. With preventive care spend at only around 4%, how do you see a greater spend shift from downstream care to primary care, both diagnostics and customized interventions, especially in an ecosystem led by hospital-led systems that have very different incentives?
I'll take this. I think the biggest shift in our healthcare in Saudi is built on building a robust primary care. And if you look to all the regulatory and the payment is toward encouraging clients, I won't use the word patient, to go to primary care, where it is the hub for doing the preventive. So we are in the arena of, there was a rule and regulation started 2 years, but was on hold, about primary care gatekeeping model, because there was a lack of maturity in the market in the primary care. And I can proudly say, in the private sector, we are very ready for the primary care gatekeeping model, and we do encourage all stakeholders to I would say encourage and push for that model, because the only way to increase the prevention and the continuity of care and the care coordination, if you have a coordinated care that built on a robust primary care, built on a primary gatekeeping. And I'm sure Engineer Mohammed would like to elaborate more on this.
Yeah, absolutely. Because I love that question, and that's why we embedded MENA into our model, because we know that 70 to 80% of the services can be given at primary care. But the problem or the gap is that having high quality primary care providers, and that's why we said if we want to do it right, let's start by doing a model led by us, and we are sure that it will spread afterwards with many introductions and investments in primary care. Because it will yield, with the triple aim, the better medical outcomes, the lower cost and higher satisfaction for the members and the patients.
Okay, so another sort of double question, slightly touched on it already, but how are high-risk patients monitored at home? And what is the integration business model between MENA Emergency or Urgent Care Center and the hospitals?
This is a great question. And as I said earlier in my intro, we built all our programs on a very strong, robust case management. So our high-risk patient and monitored closely during in-hospital stay by a case manager who actually hand them then to a home care, hospital, what we call it hospital at home, using the case managers who follow and the continuity of care, monitoring the care plan being executed. If there is need for a close remote monitoring will be in place. So we have that closed loop communication using the case management to ensure there's a safe transition of care for our high client. As we know in healthcare, the biggest adverse event can happen in the transition of care, and the only way to ensure that being mitigated is through a robust case management using the AI and digital capability to monitor our clients.
Now we have a whole bunch of questions that kind of come together under sort of how do you make it work? So I'll sort of be asking a few of them, but they're effectively what advice would you give other people? So we can start with, what advice would you give in applying VBHC? Where would you start?
I think, as Engineer Mohammed summarized, it's a long journey, but you need to start small, show early wins, and start with the things that you can achieve success quickly. For example, if you want to start with the, especially in the insurance sector, if you want to start showing outcomes on your low risk or no risk client, you're going to wait 3, 5, 10 years to show an outcome. But if you start on your high risk group and apply your case management, apply your quaternary and tertiary prevention, you can show outcomes in 3 to 6 months. So I would say understand your population, know the risk stratification, and start applying and showing early wins. And open communication with your provider is the key to success. Anything, Engineer Mohammed, you want to add?
No. I agree 100%. Is the easy wins is the key, Grace, and the rest of the audience. If you have, it's a very, very heavy ship, to steer. But once you start rolling, the success will continue. So celebrate small wins, and you see that the dice will be rolling.
So what advice would you give to other insurers who are still hesitant to take the leap into VBHC?
Start today. Don't wait for tomorrow. And we are, and I would say we have open hearts and arms to share experience. We want this to succeed because the only way to sustain a healthcare industry for the benefit of everybody is to bargain on the journey of the value-based healthcare.
Was it difficult to get buy-in within your insurance company in the first instance to implement VBHC? For example, I assume there was a large starting cost to develop your population health management approach. Great to see the outcomes down the line that you just presented around LOS, readmissions cost, etc. We've actually had a couple of questions around how long did it take, how much did it cost? So I'm curious to hear what you can share about your experience there.
I can start and I'll ask Engineer Mohammed to complete. So it is never easy, but again, I think it is open us, the health expert and the policymaker and the healthcare sector, to make it feasible, touchable, executable for the decision maker in the industry. Because if we keep talking about value-based healthcare as general principle, as theory, and as an evidence, without executing in the ground examples and showing early success, you will have resistance. If you I'm very proud of our CEO today, the engineer Mohammed, who is an engineer. But if he talks about the value-based healthcare and BHM, you would expect, and he is actually, I would say, a BHM expert. So, Abu Aziz, you want to share our Tawuniya experience with the crowd?
Maybe because I'm engineer, very rational. So we said let's convert it from subjective theory into objective reality. And we started small implementation, small pilot, small case study, and we made it happen, and we showed it in numbers that it is real. It makes, and Dr. Hadi and Dr. Kamal, they showed the improvement in medical outcomes, the reduction in cost, the improvement in customer satisfaction. These are all real numbers that gave us the courage and the motivation to keep going.
Right. Another sort of slightly more granular question. For value-based contracting or payment models, how did you consider different costing factor variables, either materials, different costs, or complications? Will comparative results be published, or are you planning to publish them for review and evaluation by all stakeholders for the same procedures on different providers with info on representative population sample details? So basically, are you planning to publish any benchmarking data?
Dr. Kamal?
So the first step was to understand the historical data for this provider, building the baseline based on item-based activity. So we understand our history. We did some sort of shadow billing, as mentioned by engineer side, with the provider, just to assure the provider that there will not be any financial loss for them. The next point regarding the publishing part, I think already engineer side presented the QR code for our Tawuniya value-based healthcare white paper. You can find a lot of valuable information on this white paper. You can understand the methodology, the process that we follow to make this happen.
And then, so do healthcare workers see the new approach in everyday practice? Were there any surveys amongst doctors, nurses, other healthcare practitioners?
So I would say we started with the provider in general, but in our journey we are going, we're actually moving to the individual practitioners. So I think we're as we go mature in our journey, we are reaching more to our individual practitioners. And again, I'm using this venue to call upon everybody interested, reach out to us. We really want to do this together.
And I think there's a sort of collective question around, getting providers to engage in efforts like this is often a challenge, getting stakeholders to engage. Did you face any resistance from providers? And if so, how did you handle it?
I can't take this, Grace. I think the word that I would use is, rather than resistance, is skepticism, worry, because the risk is high and the stakes are big. And the tolerance for failure is very small. The margins are little. And the right approach, to tackle this is to go step by step and try to find de-risks of any worry a provider might have. Dr. Khan mentioned that the biggest motivator is volume. So when we talked about announcing that provider X would be a center of excellence for ophthalmology, for example, in our cataract, so that got him interested. He was worried, that the cost of complications might not be covered if we agree on a bundled payment. So we told him, let's do it on a shadow billing basis. And we, after 1 month, 2 months, 3 months, we'll compare the two together. And then we measure the medical outcomes. We see after longer period of time, 3-6 months, what is the overall cost for that patient? Converting the very big agenda and transformation into smaller pieces is the way to go, is the key to the success of this journey.
And we have another question about preventive models or preventive interventions. In what ways is the current reimbursement model discouraging preventive interventions, and what policy levers can reverse this trend? mean, I think we've touched on it already, but do you have anything else to say about preventive interventions?
I think just keep pushing on the encouraging the provider to invest in the prevention and to achieve their financial target rather than waiting for the complication. It's a long journey. I think we start early, seeing the early adopters, and it's a journey. I think we have the right recipes in place. It's just a matter of time, and we'll see soon the outcomes.
And then finally, I just have sort of one sort of tripartite question for you. What was the biggest obstacle or challenge as you were going through this journey? What was the most surprising thing that happened as you went through the journey? And what do you think the biggest opportunities are going forward?
Engineer Mohammed?
If you allow me to start, Dr. Hadi and Dr. Kamal, is that I think the biggest one is the culture mindset within. If you have the buy-in from within your organization, and it starts from the top, what the introduction that was done by Dr. Uthman is, that's a passion that we have. It's not just a job. We always say this is not just a job for us. We really want to be part of that legacy that will be appreciated, that we contributed to the transformation from a very painful legacy that we're not happy with and to contribute to the transformation. Once that's in place, then the level of energy will be much higher, and embarking into the rest of the journey will become possibility. I would say the biggest surprise is the acceptance and the collaboration of the providers. That is also always being seen that it will be the hurdle and it will be the showstopper. But once the numbers are put in place and it gets converted into fact based and the win-win is realized, then again the level of collaboration and encouragement and positive energy will be in place.
Anything else? Any other words of wisdom before we wrap this part?
I would say don't wait to start today, and start with something simple that you can achieve with your provider. It is keep talking about it will never move the needle. Doing something about it, it will definitely help create the momentum. So start today, don't wait.
Fantastic. Well, thank you. Oh, sorry, go ahead.
Yeah, I would like to add that it takes three things to succeed: people, process, technology. So always start with people, and you can see from this level of engagement in this webinar how passionate the people are in this model. Process, understand your current process, streamline the process between contracting team, clinical governance team, and the provider teams as well. And finally, find the best fit technology that fits your model.
Fantastic. That's great advice. Well, I must say so many thank yous to Dr. El-Nazi, Dr. Kamal, and Engineer Assaid. Really, it's been such a fantastic session. I cannot thank you enough for your participation. I think we've all learned a huge amount about Tawuniya and about how we can apply some of these principles in other settings. So huge thank you. And I'd also like to thank our team at ITROM, particularly Sarah and Anya, who've done a fantastic job in sort of the background putting this webinar together. So thank you all so much. I really appreciate it. And I think we've got a couple more announcements coming up. So we've got our next webinar next month, 23rd of May, Saudi Germans Path to Better Outcomes, VBHC, from back pain and diabetes care. Again, it's free to join. Please feel free to attend, share the message with anybody you think would be interested. And it'll be a similar format to this one. And then finally, I think we've really experienced the benefits of discussing, the ITROM, VBHC part with our partner Tawuniya, but there are lots of reasons to partner with us, to develop and publish your data, to learn more about VBHC, and to create this sort of like holistic vision of VBHC going into the future. So if you're interested, please feel free to contact us, particularly Jose Delgado, whose email is at the bottom of this slide. Next slide, please. And you can see here a number of our fabulous partners for this year. We're really grateful to everyone. And I think we're really starting to put together some fantastic programs and finding ways to really cooperate and, create this community around VBHC. Next slide, please. And then finally, if you'd like to learn more about VBHC, and I can personally attest to this, having just completed cohort 1 myself, We are partnering with iTrome on education to deliver a certified value-based healthcare professional program. It's absolutely fantastic. It's about 15 weeks. It's pretty intensive, lots of reading, really great discussions. It's such a fun way to learn, and I think everybody got a lot out of it. So I would really encourage you to consider it if you are interested in learning more about VBHC. Then we can get into in a single webinar. It's a great resource, and I feel like I've really learned a lot. And I think that's pretty much coming to the end of our slides now. I really want to say a massive thank you again to everybody that's participated in this webinar, particularly our panelists. And I hope you have a lovely afternoon, morning, evening, night, wherever you are. I really appreciate you coming, and thank you so much.
Thank you so much for you, Grace, as well. You have been great. Thank you very much. Thank you to iTrome.
Thank you.
Thank you, Grace. Thank you, Akram. Goodbye, everybody.
Bye.